What is neuroleptic malignant syndrome? Let's keep it simple. NMS is a serious reaction that can happen when someone takes antipsychotic medication. Antipsychotics work by blocking a brain chemical called dopamine. Most of the time that is helpful. It calms psychosis and treats mania. But sometimes the body reacts badly to that dopamine blockade. The brain's systems for controlling movement, temperature, and consciousness start to break down. And when that happens, the patient can become critically ill. The good news is that if you recognize it early and treat it correctly, patients survive. The problem is that it can be missed because it develops slowly, and the early symptoms look non-specific. This module is going to give you everything you need to spot it, to diagnose it, and manage it. Why does blocking dopamine cause such a serious problem? To understand this, you need to know that dopamine receptors exist in several different parts of the brain and nervous system, not just the ones we want to treat. When antipsychotics block dopamine, they block it everywhere. In the part of the brain responsible for movement, called the nigrostriatal pathway, dopamine normally keeps movement smooth and controlled. Block that, and the muscles become rigid and stiff. In the hypothalamus, the brain's thermostat, dopamine helps regulate body temperature. Block that, and the thermostat breaks down and the temperature climbs uncontrollably. In the spinal cord, dopamine helps keep the automatic functions of the body, heart rate, blood pressure, stable. Block that, and those functions go haywire. NMS is what happens when all three of these systems break down at the same time. 3 pathways, 3 consequences. Movement pathway blocked means stiff muscles. Temperature center blocked means fever. Autonomic pathway blocked means unstable heart rate and blood pressure. It is not random, it follows directly from where dopamine receptors are. What does NMS actually look like? There are 4 warning signs. First, a high temperature, not a mild fever. The temperature climbs above 38, 39, 40 degrees. The body is generating heat it cannot control. Second, stiff muscles. The whole body becomes rigid. If you try to move the patient's arm, it resists with heavy uniform stiffness, like bending a metal pipe. This is called lead pipe rigidity, and it is the most recognizable feature of NMS. Third, a confused mind. The patient becomes confused and less responsive. They may stop responding to questions. In severe cases, they become unresponsive. Fourth, an unstable body. The heart races, the blood pressure fluctuates, the patient sweats profusely. All of the automatic body functions are going wrong at once. If a patient on antipsychotics develops any of these features, especially rigidity and rising temperature together, think NMS immediately and act. 4 signs: temperature rising, muscles going rigid, mind going confused, body going unstable. Any patient on antipsychotics showing these signs needs immediate assessment. Do not wait. Which drugs cause NMS? The obvious answer is antipsychotics, but the real answer is broader than most people expect. Any antipsychotic can cause NMS. The older, stronger ones like haloperidol carry the highest risk, but newer ones like olanzapine, risperidone, and even clozapine have all been linked to NMS cases. Lower risk does not mean zero risk, but here is the surprise that catches many doctors and nurses out. Anti-sickness drugs can also cause NMS. Metoclopramide, often given for nausea and vomiting in general hospitals, emergency departments, and even in the community, works by blocking dopamine receptors. That makes it capable of triggering NMS, and it is the most common non-antipsychotic cause. Prochlorperazine works the same way, and in patients with Parkinson's disease, suddenly stopping levodopa, their dopamine replacement medication, can also trigger NMS because the dopamine system suddenly collapses. The drug list is longer than just antipsychotics. Metoclopramide, the standard anti-sickness drug, can cause NMS. That is the one that gets missed most often. Always check what anti-sickness medication a patient is on before dismissing NMS. Not everyone on antipsychotics gets NMS. So who is most at risk? The first and most important risk factor is the drug dose and how fast it is increased. Going too high too fast is dangerous. The dopamine system is overwhelmed before the body can adapt. The second is dehydration. And this one is important because it is preventable. A dehydrated patient on antipsychotics is significantly more vulnerable to NMS. Making sure patients are well hydrated, particularly in hot weather during illness or after a period of poor fluid intake. genuinely reduces the risk. Having had NMS before is the most powerful predictor that it will happen again. If a patient's notes say they had NMS in the past, every prescriber who follows needs to know that before prescribing any dopamine-blocking drug. Young men are about twice as likely to develop NMS as women, and underlying brain conditions, dementia, neurological illness, increase vulnerability. Slow the dose down. Keep the patient hydrated. Check the notes for previous NMS. 3 simple actions that could prevent NMS before it happens. Prevention is always better than treatment. How fast does NMS come on? This is one of the most important things to understand because it is very different from serotonin syndrome and other drug reactions. NMS is slow. It creeps in over days, sometimes weeks. Most cases appear in the first 2 weeks of starting or changing an antipsychotic. The symptoms develop in a typical order. The muscles start stiffening first over the first couple of days. Then the temperature begins to climb. Then the heart rate and blood pressure become unstable. By the time all 4 warning signs are present, the patient may have been unwell for a week or more. This slow onset is why NMS can be missed. The early symptoms can look like flu, muscle soreness, or agitation, and the connection to the antipsychotic is not made. One more important point. Once NMS is established, it does not disappear the moment you stop the drug. It can persist for days even after the drug is stopped. For patients on depot injections, long-acting antipsychotic injections, the drug continues releasing from the injection site for weeks, meaning NMS can last much longer. The slowness of NMS is both what makes it dangerous and what makes it recognizable when you know what to look for. Muscles stiffening before the temperature rises, that's your early warning. By the time the temperature is climbing, the muscles have been stiff for days. The muscle stiffness in NMS is unlike anything else. The clinical term is lead pipe rigidity, and that name is perfect. If you try to bend the patient's arm, it does not spring back. It does not bounce, it just resists, with the same heavy, unyielding stiffness throughout the entire movement. Like bending a metal pipe, this stiffness affects the whole body, both arms, both legs, the trunk, the neck. It is constant, not intermittent. And it is this continuous severe muscle contraction that directly causes 2 major problems. First, the muscles are burning energy constantly, which generates enormous amounts of heat. That contributes directly to the dangerous temperature rise. Second, the sustained contracting destroys the muscle fibers themselves, releasing a substance called myoglobin into the blood, which can then damage the kidneys. One clinically vital point. There is no clonus in NMS. Clonus, where you dorsiflex the foot and it bounces rhythmically, is found in serotonin syndrome, not NMS. In NMS, the reflexes are normal or even reduced. That single examination finding separates the 2 diagnoses. Lead pipe rigidity. No clonus, normal or low reflexes. That is the neuromuscular fingerprint of NMS. If you feel that heavy, constant, whole-body stiffness in a patient on antipsychotics and their temperature is rising, that is NMS until you prove otherwise. Why does the temperature in NMS get so dangerously high? There are 2 separate things happening at once that both push the temperature up. First, the brain's thermostat breaks. Dopamine in the hypothalamus helps the brain regulate temperature. Block that dopamine and the thermostat loses its reference point. The body stops being able to cool itself down properly. Second, the stiff muscles are generating enormous amounts of heat. Continuous severe muscle contraction is like a machine that cannot be switched off. It burns energy and produces heat relentlessly. Both mechanisms together drive the temperature to dangerous levels. Above 40 degrees, the consequences begin to cascade. The muscles begin to break down. This is called rhabdomyolysis. An enzyme called CK, creatine kinase, is released from the damaged muscle cells into the blood. In NMS, CK levels can be extraordinary. Above 1,000 is significant. Above 10,000 is serious. Above 100,000 is severe NMS. The broken down muscle releases a protein called myoglobin, which travels to the kidneys and can block the tiny tubes there, causing kidney failure. The CK level is your severity guide. A normal CK is under 200. A CK of 50,000 in a patient with rigidity and fever, that is serious NMS and the kidneys are at risk. Check CK urgently and recheck it frequently. What happens to the patient's mind and body in NMS? Let's talk about the mental changes first because they look very different from serotonin syndrome. In serotonin syndrome, patients are agitated, restless, distressed, unable to stay still. In NMS it is often the opposite. The patient becomes quieter, confused, then drowsy, then less and less responsive, a state called stupor where the eyes may be open but the patient is not tracking or responding, and in the worst cases coma. This quietness can actually cause NMS to be missed, because a confused patient on a psychiatric ward who is becoming less responsive might be assumed to be oversedated or just unwell. The connection to NMS is not made. The body's automatic functions also become unstable. The heart races. The blood pressure does not just go high, it swings up and down unpredictably, which is characteristic of the autonomic system losing control. The patient sweats heavily, the body attempting to cool itself but without the ability to succeed because the thermostat is broken. A patient who is becoming quieter and less responsive on antipsychotics is not just over-sedated. That progressive quietness combined with muscle stiffness and a rising temperature is NMS. Do not mistake it for improvement. What will the blood tests show in NMS? First and most important, CK creatine kinase. This enzyme is released from damaged muscle cells. In NMS it can be dramatically elevated, values that in any other context would be considered extraordinary. Above 1,000 is significant. Above 100,000 is not unusual in severe NMS. The CK level tells you how much muscle damage has occurred and tracks whether the patient is improving or deteriorating. Potassium. The damaged muscles release potassium into the blood, which can rise to dangerous levels. High potassium can cause dangerous and potentially fatal heart rhythm abnormalities, so ECG monitoring is essential. Creatinine. As myoglobin from the broken down muscles reaches the kidneys, the kidney function starts to fall. Rising creatinine means the kidneys are being damaged. The white blood cell count goes up, which can look exactly like a serious infection. This is a common source of confusion. The patient gets treated for sepsis when they actually have NMS. Serum iron is consistently low in NMS, a useful supporting clue when the diagnosis is uncertain. And blood gas shows metabolic acidosis from lactic acid buildup in the continuously contracting muscles. CK, potassium, creatinine, white cells, those are the four to check urgently. CK tells you severity, potassium threatens the heart, creatinine tells you about the kidneys, and high white cells can look like sepsis. Do not let that distract you from the real diagnosis. How do you diagnose NMS? The first thing to understand is that there is no single blood test or scan that says yes or no. NMS is diagnosed by looking at the patient, their symptoms, the physical examination, and the drug history together. The diagnosis requires three things. First, the patient must have been taking a dopamine-blocking drug. This is your starting point. If there is no antipsychotic or dopamine-blocking drug in their history, NMS is very unlikely. Second, there must be significant muscle stiffness. This is the central diagnostic feature. Without rigidity, the diagnosis is uncertain. Third, you need at least two additional features from the list: fever, sweating, fast heart rate, unstable blood pressure, confusion, elevated white cell count, or high CK. In practice, when you have a patient on antipsychotics with lead pipe rigidity developing over several days, a rising temperature, and a CK level that is going through the roof, you do not need to wait for a committee decision. That is NMS. Start treatment. The investigations guide the severity assessment and monitor the response. They do not need to be complete before treatment begins. Drug history, rigidity, two supporting features. That is your diagnostic checklist. And when those three things are present in a deteriorating patient, you do not wait. You stop the drug and start treatment. The investigations confirm and guide, they do not delay. This comparison is one of the most important things in this entire module because the treatment for each condition is the opposite, and giving the wrong treatment makes things worse. Both NMS and serotonin syndrome can cause a high temperature, a confused patient, and an unstable heart rate and blood pressure. So how do you tell them apart? You examine the muscles. In NMS, the muscles are heavy, uniformly stiff, the whole body rigid, and the reflexes are normal or reduced. There is no bouncing. In serotonin syndrome, if you dorsiflex the foot and hold it, the foot bounces rhythmically against your hand. That is called clonus. The reflexes are overactive. Completely different. The speed of onset is your second clue. NMS develops over days. Serotonin syndrome erupts within hours. And the drug history, antipsychotics cause NMS, while serotonin syndrome is caused by antidepressants and other serotonin-boosting drugs. The treatments are opposite. For NMS you give bromocriptine, a dopamine activator. For serotonin syndrome, you give cyproheptadine, a serotonin blocker. Give them the wrong drug and you are actively worsening the condition. Is there clonus? No stiffness and no bouncing. Think NMS, bouncing at the ankles with brisk reflexes. Think serotonin syndrome. That one physical test decides which direction you go with treatment. Learn it, use it every time. What is the first thing you do when you suspect NMS? Stop the drug. Right now, every dopamine-blocking drug the patient is taking, not just the one you think caused it, all of them. This is the single most important action. In mild and moderate cases, stopping the drug with good supportive care can be enough for the patient to recover. The body needs the dopamine blockade to lift so the systems can start recovering. While stopping the drugs, start IV fluids immediately. Dehydration makes rhabdomyolysis worse and speeds up kidney damage. You want the kidneys flushing out the myoglobin as fast as possible. Set up continuous monitoring. Temperature needs to be tracked continuously, not just every 4 hours. The temperature trajectory tells you whether the patient is getting better or worse. Monitor heart rate, blood pressure, and urine output. Get a CK urgently and plan to recheck it every 6 to 12 hours. The CK trend tells you if muscle breakdown is continuing or stopping. If the patient is on a depot antipsychotic injection, you face an additional challenge because you cannot retrieve the drug from the injection site. But you can still stop any oral dopamine blockers, and you need to plan for extended supportive care while the depot continues releasing. Stop the drug, start the fluids, monitor continuously. Those 3 actions in the first 10 minutes give the patient the best chance. Everything else comes after these 3. Once you have stopped the offending drug and started fluids, what do you actually give? 2 drugs are specifically used for NMS. The first is bromocriptine. This drug is a dopamine activator. It switches dopamine receptors on, directly counteracting the blockade that caused the NMS in the first place. The Maudsley guidelines recommend starting at 2.5 mg every 8 hours, which can be increased to 5 mg every 8 hours if needed. The maximum dose is 40 mg per day. If the patient cannot swallow because of their reduced consciousness, bromocriptine goes down a nasogastric tube. The second drug is dantrolene. This works completely differently. It targets the muscles directly. It blocks the calcium release mechanism inside muscle cells that makes them contract. By doing that, it directly reduces the lead pipe rigidity. And when the rigidity reduces, the muscles stop generating heat, which helps bring the temperature down. Dantrolene is given into a vein, 1 to 2.5 mg per kilogram of body weight, and can be repeated as needed. The 2 drugs work beautifully together. Bromocriptine addresses the root cause by restoring dopamine, and dantrolene addresses the immediate danger by stopping the rigidity and heat generation. Bromocriptine reverses the blockade. Dantrolene stops the muscles. Together they address both the cause and the most dangerous consequence of NMS. Know the doses. The Maudsley is precise on both. When does NMS need ICU? The threshold is simple. Temperature above 40 degrees combined with severe rigidity and a patient whose consciousness is deteriorating. This is a critically ill patient and the ICU is not a last resort. It is where they need to be right now. The priority in ICU is getting the temperature down and stopping the muscle destruction. Active cooling, ice packs placed in the armpits and groin, cooling blankets, cold intravenous fluids. This works by physically removing heat from the body. And here is a common mistake. Reaching for paracetamol. Do not. Paracetamol works by lowering the temperature set point in the brain's thermostat. In NMS, the thermostat is already broken. The fever is not being driven by a high set point, it is being driven by the muscles generating heat. Paracetamol simply does not have the right mechanism of action here. IV dantrolene is what you use. Stopping the rigidity stops the heat generation. If the muscles are so rigid that the chest wall cannot expand properly and the patient cannot breathe adequately, intubation and full muscle paralysis may be needed. When you paralyze the muscles completely, all muscle activity stops, the heat generation stops, and the temperature comes down. The other complications to manage are kidney failure from myoglobin damage, which may need dialysis, and dangerous heart rhythm abnormalities from high potassium, which need urgent treatment. In severe NMS, you are fighting on several fronts at once. Cool the body, stop the muscles, protect the kidneys, manage the potassium. Each one can kill independently. The ICU team manages all of them simultaneously. Can a patient who has had NMS ever go back on an antipsychotic? The answer is yes. but carefully, deliberately, and not immediately. The Maudsley guidelines recommend waiting at least 2 weeks after the patient has fully recovered before even considering restarting. And full recovery does not just mean the patient looks better, it means the temperature is completely normal, the CK has returned to normal, and the mental state is back to baseline. All three, not just improved, fully recovered. If restarting is necessary, and for many patients with schizophrenia or bipolar disorder, the psychiatric illness makes it necessary, use a different antipsychotic, not the same one that caused the NMS. Choose a lower potency option and start at the absolute lowest dose, increasing extremely slowly over weeks rather than days. Monitor the temperature and CK regularly in the weeks following restart. At the first sign of either rising, stop immediately. And the final action, write NMS clearly in the patient's medical notes. Document it as an adverse drug reaction. Add it to the allergy section of the record, because the next doctor who sees this patient in a year, in 5 years, in a different hospital, needs to know before they prescribe. 2 weeks, different drug, lowest dose, slowest titration, and write it in the notes. Those 5 things protect the patient not just now but in every future encounter with healthcare. The documentation is not paperwork, it is patient safety.